Hello, my name is Vahe Badalyan. I'm a pediatric gastroenterologist at Children's National in Washington, D.C., and it's a pleasure and honor to present to you on the topic of functional constipation and its medical and surgical management. Pediatric constipation is a common medical problem, and it's affecting up to 1/3 of the children worldwide. It often requires long-term treatment. Relapses are common, and up to 25% of patients continue experiencing difficulties, even as adolescents and adults. Symptoms of pediatric constipation include hard and painful stools that are not frequent, abdominal pain, distension, bloating, as well as fecal overflow incontinence in patients that have fecal impaction. Urination accidents, enuresis, and infections can also occur with constipation. Most pediatric cases of constipation are functional or idiopathic, meaning that there is no obvious disease or anatomical defect that can explain it. Thankfully, organic causes of pediatric constipation are rare, but can include Hirschsprung disease, anorectal malformations, spinal cord abnormalities, and diseases of thyroid and celiac disease. A group of pediatric and adult experts meets regularly in Rome, Italy, and develops diagnostic criteria for functional constipation. The most recent version, Rome 4, is presented below and is slightly different for infants compared to the older children. If a patient meets 2 or more of the criteria for at least 1 month and there are no other explanations for the constipation, then a diagnosis of functional constipation can be made. Constipation may occur both with normal colonic transit and also with slow colonic transit. Another important group is rectal evacuation disorders, including dysynergic defecation, when there is inability to coordinate the abdominal and pelvic floor muscles to evacuate stools because of paradoxical contraction or inadequate relaxation of the external anal sphincter, as indicated in the right bottom picture on this slide. Pathophysiology of functional constipation can be quite complex and depends on behavioral factors such as stool withholding behavior or other stress. This occurs when a child is experiencing discomfort or pain with stooling and then learns to hold the stools. Once the child starts to withhold the stools, water gets absorbed into the body and the stools become more dry and difficult to come out. This creates a vicious cycle of constipation and gets worse when there is an anal fissure that's even more painful and makes the child hold their stools even more. Other factors such as genetics, diet, for example, starting solid foods in infants or transitioning children to cow's milk, can be also important in the pathophysiology. Finally, microbiome can play a role in the development of functional constipation. So how do we diagnose functional constipation? This is a clinical diagnosis based on a good history and physical utilizing Rome 4 criteria. Some of the important aspects of history and physical are listed here. Although digital rectal exam is not required in every case, it can give some hints about the sphincter function, whether there is a dilated or impacted rectum, and whether there may be a possibility of pelvic floor dyssynergia or even Hirschsprung disease. The next several slides show red flags or alarm signs which may indicate an organic problem. For example, a delayed passage of meconium, or history of constipation since early infancy, or family history of Hirschsprung may raise the concern for Hirschsprung disease. Poor growth may indicate a chronic illness, such as celiac disease or thyroid disease. Decreased reflexes in the lower extremities or abnormal sacral anatomy may indicate a spinal cord lesion. Although this is a clinical diagnosis, certain tests can be done to rule out organic causes and to aid the diagnosis of functional constipation. Getting an X-ray of the abdomen is not routinely indicated or recommended, but occasionally is done to look for fecal impaction or to assess the stool burden, although there is certain subjectivity and variability in how these results can be interpreted. Contrast enema can screen for anatomical abnormalities such as strictures and to look for megacolon, megarectum, or redundant colon. This is especially useful to our surgical colleagues if there is a consideration for segmental colonic resection. On the right picture, seeing a transition point on the contrast enema will raise a suspicion for Hirschsprung disease, although absence of a transition point on the contrast enema does not necessarily rule out Hirschsprung disease. A rough estimate of colonic transit time can be done using Sitz markers, which are swallowed and travel throughout the colon with the stool. Serial X-rays can be done, and they will show progression of the Sitz markers. Most markers reach the rectum or evacuate within 48 to 72 hours. It should be noted that in patients who have stool withholding, this pattern may be difficult to interpret because it will also show a possible slow transit. Now we can talk more about advanced testing, including anorectal manometry, colonic manometry, and rectal suction biopsy. Anorectal manometry, as pictured in the right upper corner, is involving an insertion of a balloon inside the rectum and gradual inflation of the balloon with water to increase the volume and to measure certain characteristics in the rectum. Colonic manometry involves a colonoscopy, an insertion of a long catheter that has sensors that stay inside the colon for 24 hours and measure the colonic activity. A rectal suction biopsy, showed in the left bottom corner, is used to definitively diagnose Hirschsprung disease by looking at absence of submucosal ganglion cells and measuring the thickness of the nerve fibers. This slide shows the anatomy of the rectum with internal anal sphincter, which is involuntary smooth muscle sphincter. It has a significant role in the maintenance of fecal continence since it is responsible for over 70% of resting anal pressure due to its ability to generate tone. The internal anal sphincter is surrounded by the skeletal muscle of the external anal sphincter, which is voluntary and responds to volitional commands to contract and maintain continence or to relax and pass to stools. Anorectal manometry is the most common motility test utilized in children with constipation. It helps elicit the rectoanal inhibitory reflex, which is also called RARE. This is an automatic relaxation of the internal anal sphincter when the rectum is distended. The neurologic circuit of this reflex is shown on the right picture. When the balloon gets distended in the rectum, it triggers this reflex between the rectum and the spinal cord. Presence of this normal reflex will essentially rule out Hirschsprung disease. Absence of this reflex will raise suspicion for Hirschsprung disease, which then needs to be confirmed by absent ganglion cells on the rectal biopsy. Another scenario when rare reflex is absent is internal anal sphincter achalasia. In this case, the anal sphincter will not relax, although the rectum will have ganglion cells when biopsied. Anorectal manometry also looks at other characteristics of rectal physiology, specifically at pressures inside the rectum at rest or when the child is squeezing the sphincters or pushing, and can help diagnose dyssynergic defecation. This slide shows tracings from a high-resolution colonic manometry. On the left side, you see the normal pattern of colonic motility with propagating waves of high pressures throughout the length of the colon. These are called high amplitude propagation contractions, HAPC. These are measured after a food intake or after a stimulant laxative to see the colonic response. On the right side, you see a pattern of abnormal colonic manometry, where propagation stops midway, indicating a segmental dysmotility of the distal part of the colon. This test can be particularly helpful when deciding on surgical options, such as segmental resection of the slow segment of the colon. Next few slides show the pharmacologic options for treating children with constipation. The most common medication we use is polyethylene glycol, which is a non-absorbable polymer with osmotic properties. It is not metabolized and it has minimal side effects. This medication creates an osmotic gradient in the colon, and water gets absorbed into the stool and makes the stool softer. Polyethylene glycol 3350 with addition of electrolytes is probably the most commonly used variant of this medication. On the lower part of this table, there are listed stimulant laxatives such as Senna and Bisacodil. These are used in children who tend to have stool impaction or dilated rectosigmoid. In the past, chronic usage of these stimulant medications was avoided because it was thought that they were damaging the enteric nervous system. However, more recent research has shown that these stimulant medications are likely safe for long-term use in children. Rectal laxatives and enemas are also commonly used. In this slide shows approximate amounts of the enema by age. Newer laxatives have been tested mostly in adults, but will likely become more available in children in the future. This table shows some examples of the new agents that are quite potent and effective in adults with intractable constipation. Injection of botulinum toxin into the anal sphincter has been used for children with impaired rectal evacuation secondary to Hirschsprung disease and also anal sphincter achalasia, and it shows very good response. On the right side, there is a picture of sacral nerve stimulation involving the subcutaneous placement of a stimulator device with a lead into the sacral foramen, stimulating the sacral nerve. Biofeedback therapy and training is a good tool that's teaching children how to coordinate muscle relaxation with the use of anorectal monitoring instruments to make physiological information accessible and understandable to the child. This can be useful in cases of dyssynergic defecation, but requires a child that is mature enough to understand and to cooperate. Pelvic floor physical therapy can also be useful. Now we will talk about the surgical management of constipation. This is considered an option of last resort when medical management fails. Typical surgical methods are listed here. This slide shows the concept of antegrade enema to achieve antegrade colonic irrigation. It involves flushing of fluids with or without added laxatives through an external opening into the colonic lumen. The most commonly utilized procedures are the percutaneous cecostomy, which is shown on the right side, and the Malone appendicocecostomy, which is shown on the left side. This type of surgery is minimally invasive, safe, and has good clinical outcomes as shown here. Most common complications include stenosis and need for revision. In severe cases of intractable constipation, more aggressive surgical treatment has been considered, and it's a treatment of last resort. This slide shows a laparoscopic approach to colonic resection based on motility findings as well as imaging that shows very dilated and poorly functioning segment of the sigmoid. This option is becoming more popular over time. Another extreme option, which is rarely used, as intestinal diversion with ileostomy or colostomy. This may be used in patients who are not growing or get sick often because of diffuse colonic dysmotility, who need time to decompress their bowel and help grow and get healthier. Complications can occur in a fraction of the patients and most commonly include prolapse as well as need for reoperation. This slide illustrates a decision-making guide of surgical interventions to treat constipation based on manometry. So, for example, if the motility is normal, but anal sphincter is tight, then a Botox injection may be a good option. If colonic and anorectal manometries are normal, then antegrade continence enema may be the best option. In some cases, if antegrade flushes are not working, then colonic resection or segmental resection may be considered. In summary, functional constipation is very common in children and often is a result of stool withholding and other behavioral factors. First treatment choice is typically an osmotic laxative. There are newer pharmacologic agents that will become more available for children in the future. Finally, surgery may be beneficial in a small proportion of patients in whom aggressive medical management has failed. Thank you for your time and for your attention.